Okay, well, we'll just get started here. We have that Dr. Bhatnagar. He's a cardiology fellow, third year, heading to University of Texas for a interventional cardiology fellowship, and he's going to talk today about valvular heart disease and what can we do for it.
Right. Thank you so much. Thank you, Dr. Lupu. And thank you for having me here. Thank you for coming, those who have. So basically, yes, talking about valve disease and what new has come up and what we know of from before. So first, we'll just do a quick overview about from 30,000 feet above, and then drill down to some more key features, some critical advances that have recently taken place, and some things in the future. All right, let's just talk about simple burden of valvular heart disease. Valve disease is progressively increasing. Aortic stenosis is almost reaching an epidemic proportion right nowadays. The form is changing. Rheumatic valve disease is going down, as you can see in here. And degenerative valve disease has been going up. We are able to identify more patients with infections early, so rheumatic valve disease, therefore, is going down. But degenerative process with age, with the progressively aging population, has been going up. About 38.6 million patients more than 65 years of age have AS in 2010, so that number must have grown more exponentially since then. So a few reasons why critical advances, some critical advances which have helped us in diagnosing and improving the patient outcomes in these patients. We seem to know a little bit better about knowledge of their natural history, which patients to treat where. And this is exactly the second point. The patient selection timing of valve intervention is better because of their improved knowledge of natural history. And I'll talk a little bit about that. Advances in imaging have helped a lot. A lot of cardiologists are getting certified in echo, CT, and MR because that helps in evaluating and then treating valve disease. And surgical and transcatheter management of valve disease and their procedural management has improved. So this is the classic flow chart of stages of valvular heart disease. I'm sure you're all familiar with this. Going from stage A, people at risk for valvular heart disease, all the way to stage D, where with patients having a lot of problems, symptomatic and severe valve disease. Most of our diagnosis, treatment, all of that is focused on the stage D at this time. There has been some movement towards stage C in mitral valve disease, and we don't know much about how to evaluate and take care of patients in the stage A and B disease yet, but that'll be something to look out for. Aortic stenosis, let's start with that. This is a very well-cited picture, probably the most famous epidemiological study by Braunwald. Only 75 patients, but every cardiologist knows this graph. It shows basically the graph of aortic stenosis and its natural history. So long latent period, and then with onset of symptoms, right there seems to be a big dip in survival, and mortality increases. This whole graph, of course, has shifted towards the right since 1968 when this was published. And like the average age of people who went under the partner trial for TAVRs is actually in the 80s. But the key concept the basic concept that this graph shows still remains, that the onset of symptoms heralds a worse prognosis. All right, diagnosis is after physical and history and physical is by echocardiography. Previously, we used to do a lot of cardiac cath, going across the valve with a catheter and measuring gradients, and then using it in a formula to get the valve area. Nowadays, echo is the primary means of diagnosis. The three main hemodynamic criteria we use is gradients of more than 40, a peak velocity of more than 4 meter per second, and a valve area of less than 1. And I'll just point out, because I'm not sure how much familiar these echo findings are, is that the aortic valve area is not a planimetered one. It's calculated by the gradient. So the top two are actually the more important ones. I say that because this new entity, relatively new entity, is low gradient severe AS. Now it's well known, but it's an important entity to know that the fact that there can be severe aortic stenosis without gradients being very high, and usually it's because of decreased cardiac output or decreased output to make that gradient. So it can be either because of decreased systolic function, like in this category, and the even more difficult to diagnose paradoxical low flow, low gradient, where they have a normal EF, but the stroke volume is low. So they're not able to produce enough output to make that gradient, usually in small hearts, basically. So some future trends in aortic stenosis looking forward. If you see that graph on the left lower corner, calcification is preceded by inflammation, and a lot of our current imaging and diagnosing and treatment is all focused here. But there have been studies that show that catching people early is now a thing. So they can undergo PET scans and see, like these two patients are having PET scans which show a lot of inflammation in the aortic valve, and they progress to have a lot of aortic sclerosis and stenosis. And this could be not only a marker for patients who are going to progress, but also possibly as a therapeutic target. But this for the future. Another thing for the future, role of genetics has been going on, especially in the last year. A lot of emphasis has been placed on patient-specific treatment, and Sanford has done a lot. I'm sure people here are familiar of introducing a genetic screening or trying to introduce a genetic screening in our clinical practice. Well, I'm going to tell that there lipoprotein A. I just wanted to point out one of the key features. Lipoprotein A is supposed to be an important SNP, single nucleotide polymorphism, that's shown to have a lot of effect in aortic stenosis. Now, of course, there are lots of SNPs associated with AS, also with CAD, also with aortopathy. So this is an ongoing field, so we'll see when it comes more into it. Perfect. Yeah, great. Yeah, that's exactly. It's the same with aortic stenosis. All right, yeah, we'll catch it soon. So aortic stenosis intervention, I just jumped straight to intervention. The medical treatment, everybody's familiar with. Intervention-wise, there are two main options: surgery or transcatheter management. This is Dr. Ellen Cribier, the first person to do TAVR in 2002. This was in France, so FDA actually approved it in the US in 2011. This goes to show that we are a little bit behind. We always kind of stay a little bit behind, especially with devices compared to Europe, but for good or for bad. I don't know. Anyway, so TAVR has been increasing in numbers up to 30,000 in 2016, and probably much higher right now. Initially introduced for patients with a prohibitive surgical risk. This is calculated by the STS score that surgeons use. Extreme and high risk were the first patient population to be treated, and the Partner 1 study was the one that was done for these patients. So comparing TAVI to standard therapy. Standard therapy is medications and may include balloon valvuloplasty. So across the board, there was good improvement in terms of reduction in deaths, reduction in cardiovascular events, rehospitalizations, and strokes. Then came patients with intermediate risk. These are patients who could have surgery but chose to or did not prefer to undergo open heart surgery. So there were several trials. The two more important ones were Partner 2 and SURTAVI, where they compared TAVI to surgery. And both showed that TAVR was non-inferior. Now, this is the balloon expandable valve, and this is the self-expanding valve. So both of these are non-inferior to surgery in these trials. And this led to FDA approval for TAVR also in intermediate risk patients. So yes, so as I said before, this thing here, the surgical risk, they calculate surgical risk by the STS score. An STS score of more than 15% was already approved in after partner 1, and then partner 2 and Certavi and a few others. After that, the FDA also approved for intermediate risk patient. So this is surgical risk we're talking about. Chances of things going wrong after surgery. So this is how it's done, the transcatheter aortic valve. These are the access points on the left side. Transfemoral is the most common. There are some others that people have tried. Transapical used to be a big thing before with the small thoracotomy. Some people have tried these iliac aortic conduits and carotids, and it's kind of scary stuff. But anyway, these are two major classes of valves. One is a balloon expandable here, and the other is a self-expanding, which is basically just unsheathed when it is in place. Multimodality imaging plays a big role, not only in diagnosing these patients, but in planning the treatment, which valve to put, what kind of surgery or transcatheter approach, where to go from, guiding the therapy during the valve deployment, and then following up with the patient. So this is all for echocardiogram, fluoroscopy, MRI, and CT scan. All right, there's been a trend towards simplifying TAVRs, where initially when TAVRs were first introduced in the initial trials, they were all done under general anesthesia and under TEE guidance. This has moved, but because of that, they required intubation, they required a longer hospital stay. So there's a shift towards doing these patients just under sedation and what's called monitored anesthesia care, and with transthoracic echo guidance in select patients. And actually, we did a study on that too, so I wanted to just show that we did not find a difference when we moved towards the more simplified approach. There's no difference in 30-day outcomes or readmissions or other adverse events. But there was a decrease in procedure time. Procedure was done faster because no TE required, so we did the procedures faster. But the length of stay specifically went down from 4 days to 1 day. And probably as a result of not using general anesthesia, and what was initially surgical procedure, open heart surgery is now almost a next day discharge procedure, almost an outpatient procedure because of that. Of course, I have to emphasize this is in select patients only. Not all patients can undergo this in general anesthesia, in moderate anesthesia. Yes. Oh, thank you. 175 total. Total. Yeah. This is a retrospective. About 100. Yeah. So 170. Yeah. Yeah. Almost 1 to 1. All right. So let's talk a little bit about secondary benefits from TAVR versus surgery. And this is from different trials and some meta-analysis. So, but it's generally accepted that TAVR seems to have a lower risk of neurological complications compared to surgery. It's still not low. It's 3% versus 5%. And with strokes, it seems to be pretty high. But this is the burden with the aortic valve disease. It's a calcified valve. Usually patients have lots of aortopathy also and other issues. So atherosclerosis everywhere. So the stroke risk is still high, but lower than surgery. Acute renal failure is decidedly lower than surgical risk, than surgical procedures. Major bleeding is less common. Quality of life is same as surgery, but the recovery is faster in terms of TAVR. Echo showed better hemodynamics with TAVR post-surgery, post-procedure compared to surgery. Patient prosthesis mismatch was less common. Now, patient prosthesis mismatch term may not be everybody may not be familiar. So, patient prosthesis mismatch is when a prosthesis is too small for the body size. So, a large person with a normal functioning prosthesis, but it's smaller for the body size. So, although it is sized and all, we are getting better and better in sizing the patients and to avoid this. But it seems like surgery has a higher incidence of PPM. All right, let's talk a little bit about limitations for TAVR compared to surgery. So on the extreme right side, actually, let's look at the hospital mortality first. So here, I have a mouse. 4% hospital mortality in 2014, that's relatively high for this population compared to surgery. Surgeons report about a 2% hospital mortality. But this is, you have to take it with a grain of salt that these patients are not surgical candidates in the first place, so high risk in themselves. You can see by this age cutoff that the median number of patients is 85 to 89. So old patients, higher risk patients. Vascular complications is the most common side effect or limitation of TAVRs, about 16% major vascular events in 1 year. Paravalvular leak is also seen more than surgically. Basically, it's a leak around the valve if the valve is not snugly fit with the aortic annulus. And the problem with aortic, this paravalvular leak is that more the leak, the more likelihood of events down the road. Pacemaker requirements are also higher in TAVR, about 25% in the CERTAVI trial. However, this seems to be a relatively benign finding. It did not change the otherwise 24-month mortality, and in other trials showed similar results. Valve thrombosis is a relatively new thing that we are seeing with TAVRs. This is usually subclinical though. So, as I said, the previous studies, the trials on TAVR versus surgery did not show difference in outcomes, but subclinical leaflet thrombosis was noted in patients with getting CT or other imaging for some other reasons. They found to have thrombosis. So they did a registry search for patients who have had CT and TAVR close to each other, and found that 12% of patients that, who had undergone TAVR had this thrombosis. So it's not clear why. Maybe there's deterioration of the valve. Maybe there's some other reasons. Maybe they need oral anticoagulation after TAVR. At this time, the recommendation is for dual antiplatelets for 6 months after the procedure. So I'm not sure if this will change. I think Mayo does anticoagulation routinely after TAVR. So but the national guidelines still say dual antiplatelets. Valve deterioration is the other concern because this was just approved 2011, so we don't have good data about durability of valve. Then most I saw about randomized studies was up to 6 years. In Notion trial showed 6 years, so not much more data about how long these valves last. And this is a problem with putting them in young patients and patients who can live longer because we don't know how long these valves will last. However, they're been getting safer with time, both with technology and with experience. So technology, as you see, these are different iterations of the same balloon expanded valve, SAPIEN to SAPIEN 3, and each one having less perioperative mortality or this perioperative risk. Experience also, it's been documented and studied that about 100 or more procedures, usually people are able to get their adverse events down and plateau them, so learning curve. So as more and more operators get familiar with the technology and the valves, the TAVRs will get safer over time. There have been studies about TAVRs in low-risk populations. These are ongoing. Again, the concern is with durability of the valve for a long period of time, but we'll see what these trials show. Similarly, they are studying TAVR in asymptomatic patients, also in this trial called the early TAVR trial. At this time, the asymptomatic patients by guidelines, the guideline for aortic valve replacement is basically for severe symptomatic AS. For asymptomatic patients and critical aortic stenosis, it's a class 2A indication. So there's still some indications for aortic valve replacement, but we're not, from what the initial natural history that we saw, symptoms really seem to drop their survival curve. And so this trial will be interesting to see what they show. Compared to just monitoring them, is it better to put in a TAVR earlier? All right, let's move on to aortic regurgitation. Aortic regurgitation is less common compared to aortic stenosis. Bicuspid valve seems to be one of the common reasons for seeing this. In the natural history, one thing which is very different from aortic stenosis is this here. Patients with asymptomatic but with LV dysfunction, definitely it seems to precede symptoms and seems to be a good prognostic marker actually. So at this time, the guidelines suggest that treating patients with severe aortic regurgitation with symptoms and asymptomatic patients with LV dysfunction. So the guidelines have defined them as symptomatic, class 1, asymptomatic with severe aortic regurgitation with the EF of less than 50 as a class 1 and dilated LV as a class 2A indication. At this time, there's no approved percutaneous treatments, only surgical, because of issues with putting the valves in the native valve, which is not calcified, so you can't see the valve well, you cannot hold the valve well, the position and anchoring is a problem. However, this has been tried in patients almost with a compassionate use for patients who cannot undergo surgery. Off-label TAVR has been tried. All of this goes towards an aortic regurgitation TAVR registry, and they came up with the data, showed that this was feasible. Of course, the patients were sicker, so they did have higher adverse events, but it is feasible, especially with the newer valves. Newer valves seem to do better here. There are some dedicated valves in development, most of them in Europe, some in preclinical, some in clinical also, but none in the US at this time. All right. Any questions on the aortic valve at this time? A quick rundown there. Yeah. Which one? Right. Yeah. Mm-hmm. Surgery is still recommended, yeah. Surgery is still recommended for the low-risk patients at this time, yeah. Because we have more data about that. Because we know the surgical valves, we can study how long they last. For TAVRs, we don't know yet. I think that's one of the main reasons why we prefer. Of course, patient preference we have to take care of, but approval-wise, if we show that they're low risk and surgery is not impossible, then it probably not get approved. It'll be hard to get that. Yes. Yes. So anybody with the anybody with a predicted survival of less than 1 year, TAVR is not recommended. But otherwise, it's a case by case. So there can be some other issues with, especially with bicuspid aortic valves. It's been done, but it's not been approved for that. So there are some indications where doing a TAVR might be more risky than any normal patient. Yeah. All right. Okay, mitral valve. So mitral valve is altogether different beast. The problem with the mitral valve is it's a complex valve. The mitral valve apparatus is made up of all the way from leaflets to the annulus to the papillary muscles. So dysfunction of any of these can cause mitral valve disease. Even the annulus is not straightforward; it's saddle shape. So treating this percutaneously or surgically, both ways has its own problems. And see the relation of aortic valve with the mitral valve. If we put a large valve in here, it can affect the LVOT. All right, mitral regurgitation. Commonly seen, mitral regurgitation is another entity commonly seen. One of the key considerations that I wanted to bring forward with MR was diagnosis of the etiology is most important before we start talking about treatment. Whether it's valvular disease or ventricular disease, primary or secondary. So valvular disease because of a dysfunction in valve causing MR, or ventricular disease usually because of annular dilatation causing a leak. And any cardiomyopathy can usually cause this annular dilatation. Timing of intervention is also an important consideration here. Like we saw with aortic regurgitation, there's a lot of LV remodeling that happens with chronic severe MR. And if the patients are asymptomatic, there has been studies that show that early interventions seem to do better. But you have to weigh this with the risk of the actual procedure, doing a mitral valve procedure. And with TAVRs or with aortic valve replacement, patients actually feel better after their valves are replaced. Even asymptomatic, they actually feel, they might not know that they're asymptomatic, and when their valves are placed, they might not know that they have symptoms, so when their valves are placed, they actually feel better. With mitral valve, they might actually feel worse, their EF might fall, so you have to weigh the risks and benefits. So currently the guidelines, what they say is, this was the study that showed that early surgery seems to do better compared to medical management in asymptomatic MR. All right, this is what the guidelines say in terms of when to do it early. So asymptomatic MR with LV dysfunction, and they have described that as a decreased EF 30 to 60%. And here I'll point out it's 60%, not 50%, because with severe MR, the ejection fraction is usually on the higher side because it's pumping to both the low pressure system of the left atrium and the normal systemic circulation. So 60% or less ejection fraction and a dilated LV are both class 1 indication for either a repair or a replacement. And asymptomatic MR with AFib and pulmonary hypertension is a class 2A indication for repair. These are all surgical, by the way. So the only percutaneous interventions that have recommendations is the mitral clip or the mitral repair, which is basically a small device that clips the flail leaflets, and this is only for primary MR, severe primary MR with symptoms, and patients who are not good for surgery, good candidates for surgery. So the basic device is it goes up to the veins, crosses the septum from the right atrium to the left atrium, and then goes down to the mitral valve and just holds it in place. Doesn't quite get rid of the MR completely, but it decreases the intensity. So the main trial that went into this was the Everest 2 trial, where they did looked for mitral clip versus surgery in primary MR, and showed that actually this was less efficacious than open surgical repair, and it was primarily driven by increased risk of redoing surgeries, because these patients had, as I said, because of the almost a palliative approach in which they're just decreasing the severity of MR, the intensity of MR did not remain low for a long time, so they had increased risk of redoing surgery. However, it was safer. So at this time, it's only indicated for patients who cannot undergo surgery. And it's currently indicated only for primary MR. There was a new trial that came out for secondary MR with percutaneous mitral valve repair. And this was a very highly awaited trial that just came out last year. In select patients, they had a very strict selection of patients with severe MR, which was secondary, but the left ventricle wasn't very dilated. So the mean LV end diastolic volume was about 100. In these patients, they showed that putting a mitral clip actually decreased the heart failure hospitalization and the all-cause mortality in 2 years. So this is a very recent development and kind of a shocking trial for me at least. I did not anticipate that treating MR where mitral valve was not the problem, it was secondary MR. So I didn't anticipate treating this would be a major benefit, but seems to help. So we'll see when it comes to guidelines, and more studies probably will be done on this. Ventricular disease. Yep, that's what they showed. For heart failure, yep. And this is just fresh off the press almost in September. So it's not really. I'm not sure how many people have actually started doing this, but this definitely showed a big improvement. And this was a decent amount of patients. I don't remember number of patients, but good number of patients, and it showed a substantial decrease in heart failure readmissions. And mortality too. All right. Okay, this is the next step. So the transcatheter mitral valve replacement. Lots of challenges with this. Again, similar to AR, non-calcified valves usually. So firstly, it's an anatomically complex valve. Then placing it and anchoring it in place is a problem. However, this has been tried, like this Tendyne valve. It's actually anchored with this epicardial pad, so it actually stays outside the heart and just holds this valve in place. So these valves are not very easy to deploy and are technically quite challenging, but this has been tried and it seems to work. However, it's not been approved here in the U.S. It's only on trial basis at this time. There's some upcoming other technologies also, chordal repair and annuloplasty, all percutaneous. So we'll see when they come. All right, mitral stenosis. So mitral stenosis has been decreasing in incidence actually because of decreasing rheumatic disease. Developing countries, people who come from developing countries still show up with mitral stenosis. Of course, degenerative mitral stenosis can still happen, but less commonly seen. So the echo criteria is a mitral valve area of less than 1.5 centimeters square is severe, and less than 1 centimeter square is very severe. Who to treat? Here, symptomatic severe MS is again a class 1 indication to treat. And asymptomatic, the indications are for very severe mitral stenosis, less than 1 centimeter square area, or progressive, or with AFib. Here, percutaneous options are actually class 1. If the valve is favorable morphology, if the valve morphology is favorable to valvuloplasty. And basically, we see a number of characteristics, including valve motion, valve thickness, calcification, etc. And then, if it's favorable, opening it with a balloon is a possibility. Otherwise, they undergo mitral valve replacement, and possibly in the future, transcatheter mitral valve replacement. All right, tricuspid valve. It's called the forgotten valve because we don't really talk about it too much. Tricuspid stenosis is less common. Regurgitation is very frequently encountered. Almost all the patients with heart failure or with a pacemaker in them or a defibrillator in them can have tricuspid regurgitation. Long term, the problem with this is, so this has been studied, and there has been shown that tricuspid regurgitation by itself is an independent prognostic marker. However, treating them and putting a new valve in them has not really been shown to have that much of a clinical benefit. And the trials are actually, the studies are ongoing. So right now, the indications are very limited. The indications for treating primary TR are class 1 if they're undergoing left-sided valve surgery. Otherwise, severe symptomatic TR is still class 2A, and it's a level of evidence C. So low indications at this time for treating these valves. Percutaneous therapy, again, I'm focusing on percutaneous therapy here too, but this because these valves have not been studied well in general, percutaneous therapy, of course, has not been studied well also. However, off-label TAVR has been done. This is an interesting one. I wanted to show it. This is basically a TAVR placed in the SVC and the IVC. So basically just containing the TR in the right atrium. So it's not having right-sided failure symptoms. But the TR is actually full-blown TR. All right. One important question for patients always is the choice of prosthesis, and I'm talking about surgical, mechanical versus bioprosthetic. All the transcatheter treatment, transcatheter valves are biologic. So choice of prosthesis, mechanical versus bioprosthetic, is an important question that it's a class 1 indication to actually talk to them according to the guidelines. But the main reason why we choose one over the other was shown by this study, which compared mechanical versus biologic valves. There was a slight difference in survival with the mechanical valves after 10 or 15 years. But the main reason, as I said, why we choose one over the other is mechanical seems to have a higher incidence of bleeding because they require anticoagulation. And biological valves deteriorate after some time, so they require reoperation more often. So the trend initially, and this is from a European study, Swedheart study. This is from Sweden. They have the the aortic valve registry, and what's shown is that this light gray is the mechanical valve. Can you all see it? Mechanical valve, and the dark is the bioprosthetic valve. So it seems like they initially in the 1900s the mechanical valves were much higher and more commonly used, I should say, and then more recently bioprosthetic have taken over in terms of usage. And why is that? There's some reason why. So biological valves, firstly, of course, they don't require oral anticoagulation and decrease bleeding risk. But the more important part is their reoperation risk is taken care of by the potential for valve and valve. So transcatheter valves are important here because they can be placed in bioprosthetic valves too. So valve and valve has taken up a new, it's increasing in numbers, and because of that, it seems that people have started doing, the surgeons have started preferring bioprosthetic over mechanical, even in relatively younger patients who they think that the valve may deteriorate, but they think that the technology will get better and they'll put a valve, a transcatheter valve in this older valve. Valve and ring is also a thing nowadays. If with like annuloplasty, they can put a valve in there. If there's no calcification to hold the valve, the ring can actually hold it in place. All right, so that was my spiel on valvular interventions. We talked a little bit about pathophysiology and natural history. TAVR seems to be superior than medical therapy and was favorable to surgery in high to intermediate risk patients. Risk of stroke was still there, but it was better with TAVR. Durability and long-term durability is a question that we are still finding out. Some policy questions is what is a valve center of excellence and how much training do they require for starting putting valves independently? We don't know. There's a lot of debate going on with this in cardiology circles. And mitral valve disease, the important points were to recognize the etiology, very important with MR, and timing of intervention, when to intervene. And currently, only transcatheter intervention is transcatheter mitral valve repair with the mitral clip, but there are other upcoming devices. And right-sided valves, we don't have much information, so let's stay tuned. Questions?
Is there any difference in risk for infections between surgical and transcatheter?
In the future, like endocarditis?
Yeah.
I don't know if I've seen a study about that. That'll be an interesting question. Of course, all kinds of prosthetic valves are at risk, so they all require the endocarditis prophylaxis. But I'm not sure if one is more high risk than the other. Good question. Yes.
Is the valve and ring procedure approved? Or
No.
is it experimental?
No, it's off-label.
Okay.
Yeah.
And is there a device for it? I was reading about this because I had a patient who was moving to have one.
Sure.
Made it sound like they use the aortic valve.
Yeah, they use the aortic valve, but just because they cannot use it in a normal valve without calcium because there's nothing to hold it in place. But with the ring, they can. So there's actually a valve and MAC, which is mitral annular calcification, and a valve and ring. So those three kind of more heroic procedures are being done, that have been described.